So liposuction surgery for lipedema and Dercums, as I've said many times, is not beginner liposuction. It's very complicated advanced liposuction, and it probably is the most complicated type of liposuction. And it's for a number of reasons. First of all, this is a disease. This is not just a cosmetic condition we're treating. You have to really understand that this is a disease and many different factors about the disease. Second thing, these are very complex areas. You know, if you calves and ankles and forearms and areas that get affected with lipedema are not your straight-ahead areas of liposuction. I'm in Beverly Hills, and I can tell you, even my area, there are very few surgeons that really approach calf and ankle liposuction surgery. They're more technically complicated areas. It's a widespread disease, lipedema. It's not just only little areas. It involves many areas of the bodies. And it's also a circumferential disease that we're going to talk about, too. It really wraps around body part areas. These patients are more fibrotic, as you know. You've heard the word fibrosis, and fibrosis is a fancy word for really scar tissue. You know, you get in there, and it's not just vacuuming fat out. You're dealing with a lot of fibrosis, and patients can be very soft. Patients can be extremely fibrotic, and you're spending a lot of your time just decongesting and releasing fibrosis. Patients have a tendency to bleed more with lipedema. Patients also have hypercoagulable states, factor V latent deficiency, and this and that must be considered especially. And finally, there's a lot of pre and post considerations with patients. I continue to refine and learn about all the pre and post surgical considerations on patients. So this is probably the way a lot of you feel in the audience, scratching your head about all these different terms and devices and tools and approaches that are out there. And you know, you get doctors marketing names of surgeries, you get companies pushing their devices in your face and trying to convince you that's the latest, greatest way to do this. I did a radio show for 2 years about 10 years ago. It was called The Cut Above. And I used to talk about current trends in cosmetic surgery. One of the things I talked about was all the different names for liposuction at that point. And I tried to get across like it's not really about the tools and gadgets. So what I hope to do is just clarify things for you today and be as objectively as possible, but it's a little bit difficult to not sprinkle in some subjective opinions. Let's go back. So the goals for surgery for lipedema and Dercums, they fall into two categories. Number one is the maximum treatment and prevention of the disease, symptom reduction, of course, to be lymphatic sparing. The second consideration is the cosmetic consideration. And you can look at that little graph down there, whatever it is, and see where you are on that spectrum. For some people, that may be stage 3, stage 4 patients, and they can barely walk. Obviously, the functional treatment is the main consideration, and cosmetic is less of an important consideration. And some patients, they're not having pain, and they care more about the cosmetic thing. But like I say, really, you should be maximizing both with the surgery. You should maximize your disease treatment and functional improvement of the patient, and you should maximize the cosmetic improvement in every single patient. So I like to categorize things into areas. I'm a categorizer. And I want to clarify 3 major areas of confusion that still go on. And number one is the approach with anesthesia, anesthetic approaches. Number 2 is what I'm calling the anatomic approach, how you're going about targeting areas on the body. And finally, the big area, the tools, which is another confusing area to people, and they put a lot of attention to all these words and tools. So let's start with the anesthetic approaches. So to me, again, there's 2 approaches with liposuction, and I've always felt this way. You're either approaching it under complete general anesthesia, where you've got an unconscious patient that is intubated, or you're approaching it in versions of local anesthesia, called tumescent anesthesia. Sometimes you might be combining a tumescent approach with general, but those are the 2 approaches, either purely general or you're approaching it under local. And under local, there's a couple ways to approach it too. You're either approaching it sort of purely under local with very mild sedation without an anesthesiologist, either with things like Valium or intramuscular injections or IV injections. And we'll talk about how I approach it. Or you're approaching it with an anesthesiologist in what's called twilight, which is a deeper level of sedation, but again, not general. So again, 2 approaches, general or primarily local, either with or without an anesthesiologist. So I've talked about this before, and this again gets into some personal opinions. I feel that there are advantages to local anesthesia, and so this is my preferred approach, but I think it can also be approached by those that choose to under general anesthesia. Brianna talked her first case was under local, second case was under general, and I think that's fine. But there are advantages to local. Number one is safety, and we're going to look at the next slide, and it is a safe approach, and we go historically back to some studies and stuff like that. Liposuction has had a problem under general anesthesia from a standpoint of safety, from increased risk of DVT formation to perforation of things that should be perforated rarely. So it's a safe approach. Secondarily, I feel that it's also patients tend to recover faster than general anesthesia. Not only just nausea of the gases and stuff like that, they're mobilizing themselves a lot quicker, and their recovery tends to be better. I also think that you're keeping that safe plane, and you're not jabbing things that can cause more bleeding, which can go on more so under general anesthesia. And finally, to me, the most important thing is results. I think that general anesthesia is a technical disadvantage, and that has to do with positioning of the patient in the tissue. And under a patient that's not completely under general, you can get very precise positioning and stay on that layer, especially as you're bringing that layer down and down to a thinner plane that you're working within. How am I doing, Cheyenne? Okay, I'm about 2/3 way through. So this is very quickly, this is an article that came out in 2000. This is almost 500,000 patients, multi-center study showing about a 1 in 5,000 mortality rate under general anesthesia for a number of reasons. It's a very interesting article to read. So let's go on to anatomic approaches by areas. I broke this into 3 different ways that people are approaching it. These are the ways that I think everybody's approaching it, one of these 3 ways. Either you're approaching it by sort of debulking and spot treating areas that lipedema is very active in, and you can make great improvements with that, both functionally and release areas and cosmetically. A common approach is what I'm calling the strip approach. Either you're doing things, either the medial part, and that says medical, but it should be medial and the lateral strip, or you're doing something anteriorly first and then the posterior part of it. So that to me is like a semi-circular approach and a strip approach. It's another fine way to go about doing things. And then finally, what I developed years ago, even before I got into lipedema, was this circumferential approach where you really are wrapping the entire area and leg 360 degrees all the way around. And to me, it's a circumferential disease, lipedema. And there's benefits to approaching it that way functionally, but I think cosmetically also. Tools. Okay, let's move on to this big area. So again, categorizing. I break things into non-energy-based mechanical tools and energy-based tools. So things like water-assisted liposuction is a mechanical tool. It's using a pressure spray. Power-assisted liposuction is a vibrational thing to be using as a sculpting tool. Energy-based devices, things like laser or smart liposuction, Vaser, ultrasonic energy, and finally I'm going to talk about radio frequency, which I brought into my practice and how I utilize that. This is, I'm going to rip through this quickly. This is my attempt to make something that is representing the different types of tools and how I kind of view what their strong points are from 1 to 5 stars. So we go from fibrosis release, and you go across the line there. Wall to me is okay at fibrosis release. I think it's actually limited. I use the wall in every single patient. I love it, but I think it's limited with it. I think Vaser is really great at releasing fibrosis. I think it's outstanding at helping to release that fibrosis. I think PAL is as good, quite honestly, as maybe not even better, and I use both of them, but PAL is a very effective releaser of fibrosis, that Sonicare toothbrush type of thing. Laser, not so much, and radio frequency, it's not its strong point. Emulsification, Vaser's great at emulsification, PAL a little bit less so. You can kind of see here. Skin tightening, they're all not so great. I would say with Vaser, I would take that from 1 star to probably about 2 or 3 stars. I think Vaser can give some retraction. Laser is about the same. Could be a little bit more, and I think radio frequency is actually purely tightening. That's all it's really doing, is getting thermal retraction and tightening. It goes into cellulite and nodules. I'm running out of time, so I'm not going to go into the details of it. Stuck in my mind, I think it was in Washington, D.C., it was in Washington, D.C., 2015, Dr. Stutz made this comment, "They're all metal wands under the skin." And it was, I completely agreed with it. They're all metal wands under the skin. You know, don't get too wrapped up in all these different devices and tools. It's how they're being utilized. Goals for lipedema and liposuction surgery. Again, categorization. What are we trying to achieve here? There are 2 goals. One is the fat removal. I know everybody's always focused on how much fat is being removed. And the other very important part of it is fibrous release and decongestion that you're doing, and the tissue remodeling that then subsequently goes on. There's other considerations, it's lymphatic sparing, of course, tissue retraction, and what's going on with the cellulite. So if we can go into a little video here, what do I do? To press the go thing? Going on? Okay, good. So this is was filmed by my media girl, Elena, and it's kind of showing what's going on here to give you an idea. But honestly, we're working under a blanket of the skin here, so it's a little bit difficult to see. But this is Wall, and Wall, she didn't catch it, but Wall is really a pulsing pressure spray underneath his tissue. This gives you an idea of what it's doing in terms of basically pulsing and releasing and numbing the ear. I think it's a brilliant device for numbing, and I use it really primarily as a first step to hydrodissect and to release and to numb. Second step in my practice we'll go through is using Vaser in almost every patient. I brought this in about 3 years ago. I think Vaser is a great tool that adds to things by ultrasonically further releasing fibrosis that's not completely released by the Wall, and that's why, again, I don't think Wall by itself is quite honestly enough. So I emulsify with Vaser and release more fibrosis. I may or may not do a third step in Smart Lipo. Now, Smart Lipo, this is showing how it's sort of working. You're using an energy-based device in certain wavelengths of energy to specifically do something, and I use it in Dercum. So I primarily use that in Dercum disease. This is radio frequency. Karen Herbst was in my practice about 3 weeks ago and watched me do this on a patient. And this is what I may be doing as a fourth step for further tissue retraction after I've done all that other stuff, so you get further tightening to the tissue. And it's working with radio frequency under the skin at certain temperatures, so you're not under or over treating, to get further tightening in select patients. So if there's patients that have great skin tone, they're going to retract very nicely by itself. Okay, power-assisted liposuction. This is finally what I'm using as a sculpting tool. And again, it's not exactly what I'm using, it's how I'm going about doing it, but I like PAL in terms of its ability to further release things mechanically, like a Sonicare toothbrush. But back to radio frequency, I'm using it on patients that have moderate laxity. If they have great skin tone, they're going to retract beautifully. If they have too much skin laxity, they may consider a lifting procedure. So currently, summarizing my approaches and techniques, I'm talking faster and faster here. My anesthetic approach is I don't like general, so I use it about 1% or less of patients completely general. In most patients, the majority, it's about 60 to 70%, I do mild sedation without an anesthesiologist, and I tumesce the area. In about 30 to 35% of patients, either complicated medical histories, complicated patients, or simply they're just too nervous, they'll be put under twilight with an anesthesiologist. My anatomic approach is 90% of my patients are done circumferentially all the way around, except patients that are very advanced, stage 3 plus, stage 4, lipedema patients or lipolymphedema patients. And about 10% are doing a semicircular approach. They're very advanced patients where tissue is not going to handle that. Finally, my tools, running through them. I start with Wall. It's the first step, put in the fluid. Second step is Vaser to emulsify. Third step, I may or may not use laser, but I'm primarily using Dercum's patients to lipo-zap those nodules. And fourth step may or may not involve radio frequency. And fifth step is PAL, which is not listed here. I do an average of 2 surgeries to do complete correction, and my interval time is now 4 weeks between surgeries on the average in patients. So you get past the age of 55, and I'm 57, and I feel you can quote yourself. So this is something I said many years ago. Today, many physicians rely heavily on the latest technologies and gadgets to achieve the great results, but I'm a big proponent of putting more focus on the doctor's skills, their hands, their experience, their judgment, and medical artistry. It's not about trusting the machine, but the physician behind it. It's another way of saying what Stutz said. And that was in 2004. And this is a picture of a patient out there. Actually, this is Yas, I believe, done many years ago. And this is before any of this stuff, before Wall, before Vaser, before laser, before PAL, before radio frequency. It's just well-done liposuction circumferentially all the way around. So if you ever are in Beverly Hills, this is my hairstylist, or cuts my hair. I don't get styled, but I get a cut every 5, 6 weeks or so. His name is Baptiste, a place called Umberto's, and he does great work. I highly recommend him. And these are his tools that he uses. I kind of talk about liposuction kind of being about, not about the tools, but about the person behind it. But the message here is that I've never asked him once what tools you're using to cut my hair. I just trust that he has the good experience and judgment, hands and artistry to give me a great haircut. And this is me looking quite dapper right after the haircut with Baptiste. Again, I didn't really pay attention to the tools he was using. And finally, this is my clan in Cabo San Lucas a few months ago. So thank you so much, everybody. God bless.